Renu ma'am, please indicate when to start.
Yes, sir. Yeah, you can start.
So good evening, everybody. We are here now into the fifth episode of Young Voices Expert Wisdom, and an excellent faculty lineup today with expert Madam Dr. Shubha Fadke, who has seen the entire progress of genetics in our country, who will guide the young voices who are there for today to present their cases. We have Dr. Naresh Taide, we have Dr. Chaitanya Datar, and we have Dr. Suvarna Magar, who will be presenting the cases. So we have got an excellent program lined up. Uh, I will hand over the mic now to Dr. Renu Bulawalkar to make her opening comments, and Dr. Sanjeev Joshi sir, if he is joining. So I can't see him. So I think, Madam, can you go ahead with your short
Yeah,
comments on this
yeah.
program?
गुड इव्हनिंग, नमस्कार सगळ्यांना. जेनेटिक्स म्हटलं की असं घाबरून जायचं जेव्हा आपल्याला पीजीला काही क्वेश्चन आला तर. आणि इट वॉज इन 1997 वेन आय पास माय MD, अँड आय वॉज नॉट ॲट ऑल नोईंग व्हॉट अबाउट, ओनली मगिंग इट अप and whatever the question and write it up. But over the years, so much things have been evolved in genetics, and we know that the rapid advances in genomics, they have shifted the pediatric practice from a phenotype driven sequential diagnostic approach to a genomics first precision medicine model, enabling the early diagnosis, targeted therapy, and improved family counseling. So much things have changed, and we also know that for last 10 years, rapid changes in also the genetic field has happened. Also, many diseases are being treated on the basis of this. But today, we have got a very great teacher, Dr. Shubha Fadke ma'am, who is going to be our expert guide. And welcome, ma'am, to this platform on Maharashtra Academy of Pediatrics. And also, I would like to congratulate as well as wish the best to all the three speakers who are going to present us their knowledge about the genetics as well as the various developments and what to do and what not to do, along with Dr. Taide, Dr. Chaitanya Datar sir, and my dear friend Dr. Suvarna Magar. And it will be a very great pleasure to me to praise our team of Young Voices Experts Wisdom, Dr. Praveen Gokhale sir, under whose guidance all these things have been planned and organized. And with his team, Dr. Sandeep Karle, Dr. Ritesh Bisen, as well as Dr. Mahesh, they have done a very great effort to arrange all the team members as well as the faculties. So over to you. And also I will welcome all the delegates who have joined today. And over to you, Dr. Ritesh.
Yeah, so I still cannot see our president, sir, but whenever he joins, we will give him an opportunity to address you. Our today's moderator is Dr. Ritesh Bisen, who will be moderating the session from here onwards till the end. Before that, what I would like to say about the young voices is that our intention was to bring the most young of the speakers who are establishing themselves in the field from diverse places of Maharashtra. And in this fifth episode, till now, we have been successful in giving opportunities to young voices. It is my fervent request to Madam Shubha Fadke to guide them after each of their presentation. With this, I hand over the mic to our moderator for today, Dr. Ritesh Bisen. Dr. Ritesh, please take over and start with the introduction of the participants and faculty.
Thank you, Praveen Gokhale sir. Namaskar and very warm welcome to all respected office bearers, dignitaries, faculty and pediatrician joining us from across the Maharashtra. On behalf of Maha IIP, it gives me immense pleasure to welcome you all to our fifth episode of our flagship academic series. Actually, today's topic is extremely relevant and very useful in day to day pediatric practice. As a pediatrician, we increasingly encounter children with developmental delay, congenital anomalies, unexplained neurological disorders, and various metabolic diseases. And we know that genetics has become an essential part of the modern medicine as well as in any disorder. But the key challenge for the practicing pediatrician is that when should we suspect a genetic condition during your OPD, which test should we choose, and how do we interpret the results mindfully and meaningfully. So today's session, I think, aims us to provide the answers for these practical questions. And before moving to the session, I am glad to introduce our expert as well as young voices faculties. To start with, I am very privileged to introduce Dr. Shubha Phadke Madam, who is an esteemed distinguished expert in the field of medical genetics with a degree of MD Pediatric as well as DM in medical genetics. She has a remarkable academic career, has served as a professor and head at a prestigious college of SGPJ Lucknow, as well as at present she is currently associated with Bharati Vidyapeeth. She is a pioneer actually in the field of medical genetics of India. She is also being the founding president of Society of Indian Academy of Medical Genetics, and she has contributed immensely in advanced genetic medicine in India. Her academic accomplishments are truly extraordinary. She has over 300 publications in reputed journals. She authored the book called Genetic for Clinician, as well as described 10 novel syndrome with causative genes for 6 new monogenic disorder. Her work has also earned an international recognition with multiple OMIM citations. Dr. Phadke Madam has been also honored with several prestigious awards, including Hargovind Foundation Fellowship, International Scholarship from Clinical Genetics Society of UK, as well as Dr. I.C. Verma Outstanding Research Award. She also served on many editorial boards for several reputed journals, including American Journal of Medical Genetics, as well as European Journal of Human Genetics, and is also the editor for prestigious genetic clinics. Madam, with such an illustrious career and immense contribution to medical genetics, we are truly honored to have you with us today.
Thank you, sir. Thank you very much.
Now, I will like to introduce our young voices faculties. It is my pleasure to introduce our first speaker, Dr. Naresh Tade sir. Dr. Tade sir is an associate professor at Department of Pediatric at PDMMC Amravati. Also, he served as a president of Sickle Cell Society. After post-graduation, he further specialized in field of genetics through SIMG Fellowship in Clinical Genetics as well as DHR Fellowship in Genetics. Dr. Tade sir has significant academic contribution, including 18 publications in national and international journals. With his unique blend of expertise in pediatric and clinical genetics, he is actively involved in management of genetic disorder, particularly in regions where hemoglobinopathies and sickle cell disease has a major public challenge. We are delighted to you have sir with us. I warmly welcome you for today's
Thank
session.
you, sir. Thank you.
Our second young speaker is Dr. Chaitanya Datar sir. He is a distinguished consultant clinical genetist, director of Advanced Center for Advanced Genomics in Pune. He is also associated with prestigious institute like KM Pune as well as Bharati Vidyapeeth. He has over 15 years of experience in clinical genetics and widely recognized work in dysmorphology, IEM, neurogenetics, prenatal diagnosis. He has contributed extensively to academics through numerous publication, book chapters, national, international faculty and given lectures. He also play a key leadership role in genetic societies and conferences. Sir, we are fortunate to have you with us today and thank you for joining with us.
Thank you, sir. Thank you.
Our third speaker is Dr. Suvarna Magar Madam, who is Associate Professor of Pediatric at MGM College, Chhatrapati Sambhaji Nagar, Also, she is in charge of genetic clinic at the institution. She has a training in clinical genetics with SIMG fellowship in clinical genetics, as well as she has a master's degree in neurometabolism and cell biology from the University of Barcelona, Spain. Her expertise include intellectual disability, dysmorphology, lysosomal storage disease, newborn screening, and neurogenetics. She has contributed over 36 publications in index journals, numerous citations, and also she, under her leadership, a genetic clinic at MGM became one of the center where enzyme replacement therapy for lysosomal storage disorder was initiated. Thank you, madam, for joining with us, and I welcome you on behalf of Maharashtra IIP.
Thank you, sir.
Now, without delay, we will soon be starting the most awaited session. Before starting, I request all the delegates to post your question in chat box, where your questions and answers will be discussed at the end of the session. Now I invite Dr. Naresh Tade sir to deliver his presentation on genetic testing. Dr. Tade sir, you can start the session.
Yeah, thank you. I will share the presentation. So I am very thankful for the, if I am audible?
Yes, sir. You are audible and PPT is visible also.
Okay, so I am very thankful for the IMA IIP Maharashtra for giving me this opportunity, and with presence of Dr. Shobha Phadke madam to present this topic in front of you. So our topic is demystifying genetic testing, choosing the right test at the right time. So the topic is very long and may not be possible to cover all the aspect in 20 minutes. I will be try to make it very simple for the pediatricians and clear their doubts in upcoming talks. So if I ask you to go at some place, out of this following modes available, which thing is best for travel? You can join with this mentor, join on this website by scanning this QR code, and we may get the answer. We will see the result. Okay, we go ahead before, so anyone can answer these things. So why this question is asked beforehand, before starting our points, we come to know at the end of our talk. So learning objective of today's talk is depend on the case-based discussion of different tests. This test should be done in home. Which testing we are going to prefer, basic of some genetic testing, indication of each test, and take-home messages. So we start with our case 1. So this case can be easily recognized by every pediatrician. So everyone can recognize just by looking at the face that this both the children are suffering from the Down syndrome. So it is known as the gestalt diagnosis, where you can look at the face of a child and can have your diagnosis in your mind. And if you have seen number of this type of cases, then you may be fairly sure about your diagnosis. So in this case, the diagnosis is Down syndrome. Now, which test you want to confirm your diagnosis, and what is the ideal diagnostic test for this Down syndrome? You can also answer this question on again on the this. So answer is karyotyping is the ideal test for the diagnosis of a Down syndrome. So this is the karyotype report. We can see here there is a 21 chromosomes had 3 copies at place of 2, but accidentally you can find there is a translocation between 9th and 13th chromosome. So what is the importance of karyotyping? Doing karyotyping, you can diagnose the original condition, that is Down syndrome, but you can also find if there is have any change in the other chromosomes or not. What other test which we can be done if someone wants to do for the Down syndrome? That other test is FISH. So in FISH test, we can diagnose the Down syndrome at a shorter duration and we can confirm. So what is the advantage of FISH or karyotyping in each case? So in karyotyping, resolution is low. In FISH, for specific that probe, resolution is high. Time taken for karyotyping is more compared to the FISH. FISH diagnosis may become easy, but for karyotyping, the person who is looking at the karyotype should have experience to look at and report the karyotyping. If there is a mosaicism, if only high level mosaicism can be picked up with karyotyping, but FISH is a test where if there is a low level of mosaicism, you can pick up with a FISH. And clinical diagnosis in karyotyping, if patient has other trisomies other than the Down syndrome, then also your karyotyping may be positive. But if patient has other disease rather than Down syndrome and you do FISH for the Down syndrome, you may not get answer. So it will tell you only whether the child has Down syndrome or not. That means when you are not sure and you are suspecting chromosomal disorder, you can go for karyotyping, which can look at all chromosomes and larger deletion or larger defect, number defect can be picked up. While when you want to you are very sure about your diagnosis, you can go for the FISH technique and can have your diagnosis confirmed. So as we know, this double-stranded DNA round along histone bodies and then it condense and from the karyotyping. So if you have the disease where chromosomes are involved, then you are going to do the karyotyping. But if it is a small area on karyotype chromosome is affected, then the choice of test is the chromosomal microarray. While when there is a base pair deletion or duplication or base pair change, then we require to go for the Sanger sequencing. So karyotyping check whole genome at lower resolution, change in number, large structural, sex to confirm the sex, and translocation. We can do the karyotyping. Indication of karyotyping are if you suspect the chromosomal diseases, to know the genetic sex in cases of DSD, that is disorder of sexual differentiation. Female with primary amenorrhea, short stature, and hypoplastic uterus like Turner syndrome can be diagnosed with karyotyping. Parental testing in recurrent abortion, karyotyping is must, where you cannot use microarray as your test. If you suspect ring chromosome translocation or inversion, you require to do a karyotyping. In some cancer disorder, also karyotyping is going to help. Most important, when you are doing any test, we should also know when not to do that test. So if you are suspecting microdeletion disorder like Dye-George syndrome, or if you are suspecting single gene disorder like sickle cell or thalassemia, you should not do the karyotyping. You require to go for the different set of tests. Now going to case 2. This family came for antenatal counseling as their first girl child, Saz, affected with mild autism and ADHD. She born full term by cesarean section delivery with birth weight of 2.7 kg. Meconium stain liquor is there. Baby cried immediately after birth, required 1 month hospitalization, and at the time of discharge diagnosis was MSL with meningitis with convulsion with non-oligemic renal failure. As there is a developmental delay, EEG was done at 14 months, which show epileptiform discharge, and MRI show mild prominence of ventricle with some frontotemporal atrophy. The pediatric neurologist also see in the cases, and as there is a some unusual features like hypotonia along with autism and ADHD. Clinical exam was also done and which come normal. So what are the different possibilities in this case? Whether this child has only autism or ADHD, whether this child has a cerebral palsy, and whether you want to do further testing or not. Again, you can answer this on this Mentimeter quiz, and some of us may think as whole exon sequencing is negative, so what is the need of doing the further test? But this may not be true. As per ACMG guidelines, if you have child with autism, which is have not syndromic phenotype, then also first test should be done is the microarray. Now, newer guidelines may come with whole exon, as newer generation of whole exon sequencing may able to diagnose the CNV in them. So may come as a whole exon as a first line test, but at present we have a first line of test as a diagnosis in autism without any syndromic or specific feature is a microarray. And in this case, this child is found to have 15q13.3 microduplication syndrome, which is matching with her phenotype. So now diagnosis completely changed. In autism, if it is non-genetic, risk may be approximately in second child, it may range from 2 to 4%. But in this case, as there is a micro deletion, and if it is de novo, then risk is again 1%, and we can pick up this whether the child is fetus is affected or not by doing the CVS or amniocentesis test. So when we should do the chromosomal microarray? So chromosomal microarray has a resolution of 10 kb, which is approximately 50-fold higher than karyotyping, and different type of microarray may have different resolution and detection capabilities. Indication of microarray is unexplained intellectual disability, multiple congenital anomalies, autistic spectrum disorder, fetus with malformation, and or very high knuckle translucency. So all the cases of chromosomal abnormality, when there is a number, abnormalities in a number, or there is a larger deletion, which can be picked up by microarray, but if there is a translocation, we cannot pick, it cannot be picked up by the microarray. So microarray should not be done when in asymptomatic parents we want to check whether there is a translocation or not. If similarly, if there is a single gene disorder, as we already discussed, like sickle cell and thalassemia, or phenylketonuria, or some metabolic disorder, where we cannot do chromosomal microarray as a first line test. First line test should be a whole exon sequencing or Sanger next generation sequencing, which may include whole genome or others. So now coming to case 3, this is a 3-month-old male child with difficulty in feeding, large tongue, and hemihypertrophy. His thyroid testing was normal. Alpha fetoprotein is high. So what is most likely diagnosis in this case? So I may think everyone can recognize hemihypertrophy along with large trunk, and the child most probably having the Beckwith-Wiedemann syndrome. So what is the ideal test, diagnostic test in case of a Beckwith-Wiedemann syndrome? Again, you can answer this by choosing here. So in Beckwith-Wiedemann syndrome, if you do the whole exon sequencing or microarray, sometimes it may be normal, not in every case, but sometimes it may be missed if you do microarray or whole exome sequencing. But first line test, whenever you suspect the imprinting disorder, is a methylation based MLPA. So methylation based MLPA can be is a first line test for Beckwith-Wiedemann syndrome or Prader-Willi syndrome. And in this case, we have found out that there is a loss of methylation in IC2 region. And so this is the confirmation of diagnosis is done. In this case, Sometimes if you do the microarray or whole exome sequencing, it may comes normal. So when we should do the MLPA, that is multiple ligation dependent probe analysis. It depend upon the denaturation and hybridization ligation. The technique used method of MLPA is denaturation and hybridization followed by ligation and then PCR amplification. It can detect 40 to 50 different genomic segment, and it is first line test for the Duchenne muscular dystrophy, spinal muscular atrophy, myotonic dystrophy, and for finding large deletion in some gene where your whole exome sequencing may be negative. So sometimes it can be used as a pre-form mental retardation panel for some specific disorders where specifically telomere is affected. And for methylation MLPA probe testing, we can do the MLPA test. Now, this is very easy to diagnose case. A 6-year-old child with walking difficulty, not able to stand from sitting position, and child also has a calf hypertrophy, and child is showing classically Gower sign positive. So what is the most probable diagnosis in this case? Most probable diagnosis is a Duchenne muscular dystrophy. And what first test you will do, biochemical test you will do, is a CPK. In this case, CPK is 5600. So what next genetic test we are going to do to confirm whether it's DMD or not? It is the MLPA, 79 MLPA for DMD. So we have to remember, whenever you want to choose the MLPA test, like fish testing, you should be sure what you want to look for. So if you want to look for the DMD, we have to choose the MLPA for DMD only. If you want to look for the SMA, you have to choose MLPA for SMA gene. And when you are to choose for the myotonic dystrophy, you are going to do the MLPA test for the myotonic dystrophy. So there are different tests. And so before ordering this test, you should know which disease you are suspecting. But in this case, MLPA comes negative. If that means the child is not suffering from DMD, or we require to do the another test. So we have to remember, all DMD cases may not be picked up with the MLPA. MLPA can be picked up with a larger deletion and duplication in the DMD gene. So pickup rate with MLPA is approximately, in books it mentioned as a 70%, but in our study we found it goes up to 80%. So deletion and duplication can be picked up with MLPA. But if there is a smaller mutation or smaller change, we require to do the other test. And what is the next diagnostic test in this case? This is the whole exome sequencing. So in this case, we have found there is a change in the at codon 698C, deletion of A is there, which causes frame shift mutation and causing phenotype as a DMD. So in our 103 cases of a DMD, out of which only 83 has done complete workup, means MLPA, and whenever required they have done the NGS also. We have found that 4 patient has clinical phenotype is typical of DMD, but they are found to have other differential diagnosis like LGMD, some may have SMA, and some may have a other type of muscular dystrophy, or one of the patient also has the congenital myopathy also. But so we can, phenotype may misleading in some cases, and labeling just depend upon the phenotype of the patient is not useful. We should always do the genetic test to confirm our diagnosis in this case. So coming to next generation sequencing, now what's happening ki every child with undiagnosed case, we are going toward the next generation sequencing or whole exome sequencing. But this is not, as we have seen already, this is not should be the approach in every cases. We should know when we should do the whole exome sequencing or next generation sequencing. This is the advanced version of Sanger sequencing. There is a massive parallel sequencing of multiple genes simultaneously, useful for single base pair mutation, small insertion, deletion, and newer platform may able to detect CNV, but it is not used as a primary test to detect the microdeletion disorder. So before ordering, you must know the coverage and common mechanism of disease whenever you want to do this test. When not to do? When you are suspecting simple chromosomal disorder or microdeletion disorder, you should not do the next generation sequencing as a primary test. Similarly, in a methylation disorder or imprinting disorder, first line test should not be a directly whole exome sequencing. This case 5, 6-month-old male child, is labeled as a congenital dyserythropoietic anemia on regular transfusion since 3 months of age. When he presented to us at 6 months, he has already received 3 transfusion, and his cousin brother is also known case of thalassemia major and receiving transfusion from 3 months of age. Father's HPLC in this child is thalassemia threat, but mother is normal. So hematologist considered mother can be a silent carrier, and we don't know. But at 6 months, again when he present with the severe anemia without hepatosplenomegaly and retic count very low, we have think of Diamond-Blackfan syndrome in this case, and we have done the whole exome sequencing, which confirm the diagnosis of a Diamond-Blackfan syndrome. So what happened after the confirmation of diagnosis? Child is started on steroid, and on minimum doses, he is become transfusion free completely. So sometimes genetic test may change the life of a patient from sometimes morbid or mortal disease to a simple treatment. This case 6, SRG, 13 years, 6 months, non-consanguineous marriage, full term, normal vaginal delivery, birth weight 2.75 kg, cried immediately after birth. At 9 years, there is a walking difficulty like drunken person. On examination has ataxia and knee reflexes were absent, but ankle reflexes was present. As we can see in the pedigree, it born out of a consanguineous marriage, and other 2 siblings are also affected with the similar diseases, though they are younger than this child. Girls is more severely affected than both the boys. And what is the most probable diagnosis? Most probable diagnosis is a Friedreich ataxia in this case. And what is the test of choice in this case is the triple prime PCR. So TP-PCR is a test of choice which found out that there are a GA repeat in a gene and confirming the diagnosis of a Friedreich's ataxia. So we can consider as this test if we consider our genome as a books with 46 chapters, out of which 22 chapters are in duplication and 2 chapters are considered as the X and Y chromosomes. Then if there is a chapter deletion or duplication, then we should go for the karyotyping. But if the paragraph in chapter is removed or duplicated, we require to go for the microarray. When you want to read the whole book word by word, whole book with references and all the details, then the test of choice is the whole genome sequencing. But if you want to have an important part in each chapters or important part of a book, then we are going to do a whole exome sequencing. Take home message: if you know gestalt or clinical diagnosis, then can do a specific test. If you are not aware, then which test we require to do, then you can discuss with friend having genetic knowledge or refer the child to the geneticist for doing the test. This is most important point कि always do pre-test counseling and post-test counseling after the test report. This is most of the time we miss it, and then there may cause a problem. Not all tests can be diagnosed with whole exomes. Not all disease can be diagnosed with whole exome sequencing, and not all genetic disease can be diagnosed with the genetic testing. If you can't have specific diagnosis, always better to have a geneticist opinion before testing. Now there is a lot of debate between the whether we should go for the genotype first or phenotype first. But my personal opinion is we should have phenotype handy ready before ordering the test. So we must know what we are looking for, because sometimes this test may mislead you, and once you label them with the diagnosis, that diagnosis carry forward for their whole life.
Thank you, Dr. Naresh Tade sir, for this practical and insightful approach for using various genetic tests in diagnosis different disorders as well as syndromes. May I now request our expert Dr. Shubha Phadke madam to share her expert wisdom on this topic.
Thank you, the organizing team, Dr. Gokhale and everybody. Am I audible?
Yes, ma'am.
Okay. This is a wonderful session, and the idea is excellent. As a professor of first Department of Medical Genetics in India, first we did training as super specialist, DM in medical genetics. But over years, now the most important thing is, in addition to super specialist medical geneticists, we need all clinicians, especially pediatricians, to be empowered with the genomic knowledge and tools. And from that angle, these type of activities, especially organized by various chapters of Indian Academy of Medical of Pediatrics, are very, very important. The talk by Dr. Tarde was wonderful. He really highlighted what we want to know, that all pediatricians should be comfortable and confident in ordering the test for common genetic disorders like Down syndrome, short stature Turner syndrome, DMD, SMA, and thalassemia. So he has very well given information that which specific tests to be ordered for that particular situation. The one more point I want to add is, for every patient, please draw the pedigree, because sometimes even if the clinically you don't realize that this could be a genetic disorder, but drawing pedigree and history of consanguinity or positive family history sometimes may give clue to the correct diagnosis. So the case child presenting with some muscle disorder and X-linked family history suggestive of X-linked inheritance, and then the DMD becomes first possibility. So the drawing pedigree should be first part, and then appropriate test. Now, whether to do a next generation sequencing based exome sequencing first or not, that is always debate. And here I would like to say that it should be considered in the early course of disease, in special situations where there is a very close similarities between presentation of genetic disorders and non-genetic disorders, especially in NICU settings. So there are these type of situations where we feel that probably early diagnosis may give a accurate prognosis and sometimes cure. And then NICU based testing, of course the time is very small that we cannot consider all situations, but in such situations sometimes we need to consider NGS based testing earlier. But for specific disorders, as you say, as you very well showed, that accurate clinical diagnosis is still possible, and hence good clinical skills, good history taking, and pedigree drawing still remain to be very, very important part of evaluation of patients with genetic disorders, and has to be done sincerely before ordering any test or deciding any test. And uh, NICU and many of the disorders, in addition these typical disorders, many disorders have presentations overlapping with the non-genetic disorders. Like we get many patients with diseases of bones and joints labeled as rheumatoid arthritis. So it's very important. OMIM he has shown. So everybody has to use OMIM database to, so that more and more genetic disorders you get to know. There are more than 5,000 genetic disorders, and that's a clearly challenge, but also it's a interesting diagnostic challenge for pediatricians who like to make rare diagnosis. So, use of clinical skills and use of investigations appropriately would give you many diagnoses. And at any early stage of where you feel that there are dilemmas, then referral to geneticist is always welcome. Thank you. So maybe if you have some questions, I don't know when they are planning.
Madam, we are planning the question session at the conclusion of the session.
Okay, right.
Yes, ma'am. Thank you, madam. Thank you for your pearls of wisdom. That will definitely help all pediatrician in day-to-day clinical practice. And you very insightfully explained us about the use of. Still, we have to use the clinical skills and importance of pedigree that most of the time in OPD practice we miss. And also thank guiding us on OMIM database usage in the clinical practice. Thank you so much, madam. Now we
Thank
move
you.
on our second presentation. I invite Dr. Chaitanya Datar sir to speak on approach to dysmorphic child and evolving role of genetic testing. Dr. Datar sir, over to you.
Thank you so much. At the outset, let me thank MahaAP and Dr. Oakley for this opportunity. So I've been asked to speak on approach to a dysmorphic child in an OPD and a little bit on the role of newborn genomic screening is what was told to me. So I'm talking in front of, I would say, the teacher of teachers, that is Dr. Shubha Phadke Madam, who's an expert dysmorphologist. And she has coined this term called Swarupology in one of her recent papers. So in the Western things, then they would say, rain, go away. While in our setting, we would say ere pausa. So similarly, looking at it more positively, she has coined this term Swarupology. But going by the term dysmorphism, so when you're talking about dysmorphism, it's an abnormality in the morphological development which indicates a visible or typical facial feature or a body structure. So it should be a visible feature or a structure. This is abnormal morphia as the form. But when you talk about congenital anomalies, these are physical abnormalities which could lead to a structural or functional deficits, and they can be actually visible or sometimes on systemic evaluation. Like, for example, cystic kidneys or cardiac defects are non-visible issues. So they do not classify as dysmorphism, but CTEV or a neural tube defect would classify. So most congenital anomalies would classify as dysmorphic features. So we know that various body parts have a lot of differences. If you just look at the ear helix, you can see the different types of anomalies that are dysmorphic features that can note in the ear helix. You can have a ear pit, micro ossia. You could have in satire ear, elfin ears, etc. Similarly, in the hands, you could have syndactyly, polydactyly. There can be a cleft and dermatoglyphic abnormalities. So one of the best resources is something called Elements in Morphology. This is a freely available tool online, wherein which defines different parts. Like here, they have shown that I've shown you the how they have defined hypertelorism. So that's how you can get to know the different morphological abnormalities in the face, hands, feet, etc. So what is the importance of doing a dysmorphology evaluation? Sometimes it can change the diagnosis in someone. So the patient walks in and you know what the clinical syndrome is just by looking at the patient, the gestalt diagnosis. It helps in planning appropriate investigation. So you need to identify a particular pattern which would help you in identifying which test needs to be undertaken, as Dr. Tayari just discussed various case scenarios. It gives you clues regarding which other systems should be evaluated. Like, for example, if you have a radial ray abnormality, you should also look at possibility of Fanconi anemia or other conditions. You can guide appropriate interventions like proper feeding for a cleft palate or a surgery for an absent anus. If there's a blepharophymus, you can undertake surgeries or therapies for syndromic cases. At the same time, you can assure and counsel regarding minor malformations, especially ear tags or single transverse creases. So essentially, that's the importance of a dysmorphology evaluation. How common is dysmorphic features? So this is related to birth defects. We do not have exact estimates of the dysmorphic features being present in the population, but there are a lot of minor variations which are there in all of us, which may classify as dysmorphic features. But as regards to birth defects, about 3 to 6% of infants born worldwide would have a serious birth defects as per the CDC. Now, there can be minor features and major features. So minor features are tags, epicanthic folds, polysyndactyly, or sometimes there could be an extra nipple, umbilical hernia, sacral pit dimple, various dermatoglyphic changes as such, which may be there in many of us. So they would classify as minor features which could only be of cosmetic significance, but those which are major, if they are left uncorrected, could lead to significant functional impairment. So what are the causes of dysmorphic features? So one is obviously the genetic causes, where we're discussing about chromosomal and single gene etiologies. A lot of metabolic conditions, hypothyroidism, storage disorders, certain inborn errors of metabolism can also present with dysmorphism. We must be aware of the non-genetic causes as well, like the antenatal scenario. There could be, antenatal nutritional deficiencies could cause neural tube defect, cleft lip palates. Postnatally, even rickets, vitamin deficiencies could present with dysmorphic features. Similarly, environmental causes, in utero exposure to teratogens, or sometimes ex utero due to surgery or trauma, there can be changes which happen in the overall features of the individual, or sometimes it can just be a familial trait. This particular child, the child had a single transverse crease, had a depressed nasal bridge, and a bit upslant to the palpebral fissures. So the parents were very much, they were very anxious whether the child had Down syndrome. If you look at the father, he also had a single crease. And obviously, clinically, this child did not have Down syndrome. So there can be a lot of normal variations in the population, which you have to be aware. And therefore, always we need to compare the phenotype with that of the parents. Now, teratology is one of the important disciplines in genetics, which deals with fetal malformations that occur due to teratogens. The pictures that I've shown here are essentially because of various teratogenic exposure. You can see the degree of dysmorphism that is seen in. See, like fetal warfarin syndrome or the fetal alcohol syndrome, you can identify sometimes based on the face. Though we do not identify that commonly in our population, but these conditions do have a specific face. So torch infections or alcohol, thalidomide, warfarin, all these exposures could lead to teratogenic issues. Now, if you're classifying dysmorphic features, they were classically classified as a single system and multiple system. So single system, there can be malformation, disruption, deformations, and dysplasia, while in multiple systems, there could be something called sequence, associations, and syndromes. So essentially, when we're talking about a malformation, essentially what you're seeing as a normal development is a single straight line. But in the malformation, that part or that specific region is malformed right since the conception, and that goes up to the term. So essentially, the commonest example is a neural tube defect, when you could have certain isolated non-syndromic forms, which are usually non-recurrent. It can be anencephaly, occipital or lumbar, occipital encephalocele or lumbar meningomyelocele. Or it can be a syndromic case, wherein in Meckel-Gruber syndrome, where you can have in association with occipital encephalocele, you could have a polydactyly with cystic kidneys. Obviously, these are single gene conditions, and the risk of recurrence is quite high. Similarly, if you're talking about cleft lip and cleft palate, those which are central, bilateral, and more extensive, that is cleft lip plus palate, would have a higher possibility of a genetic etiology as compared to if it was a unilateral, asymmetric, or isolated issue. So usually if it is, you're seeing the cleft lip, cleft palate, you have to look at other abnormalities as well and then consider appropriate testing. So this is a case of split hand-foot malformation. So obviously it was a twin conception and both the babies had this kind of split hand-foot malformation. And we know the single gene causes which are responsible for this particular condition. Now, in some of the cases, what happens, the tissue is developing normally, but because of some external factor, the tissue becomes abnormal. Like, for example, you're finding that there's an oligodactyly or a band. So that could be because of an amniotic band in utero as well. So you have to look for the symmetry. So you're looking at the other side as well. And if you're finding one hand is normal and the other finger is, auto amputated, you could think of a possibility of an amniotic band. So this is called disruption. Sometimes a part which is developing normally, it remains normal but is deformed. So that is called deformation. For example, congenital telepequenovirus or congenital hip dislocation, which usually would happen because of an abnormal mechanical force, which distorts the otherwise normal structure. So essentially, if CTE is isolated, it could be because of external factors, but if it is associated with other findings, it could have a genetic basis. Similarly, dysplasia. So when an abnormal organization of cells into a tissue, which affects the parts where the tissue is present, like for example, ectodermal dysplasia. So that is going to affect the skin, the teeth, the hair, etc. Or a skeletal dysplasia, which is going to affect the bones. So similarly, you have this achondroplasia or hypochondroplasia, which are dysplasias. Then sometimes we come across sequences. So sequences, like the classical known sequences of Potter's sequence. So there is a multiple abnormalities that happens because of a single initiating primary factor. Like because of the renal agenesis or some obstruction, there's a reduced urinary output, which causes oligoamnios, that causes a spot face with a pulmonary hypoplasia and dislocation of hip. Then we have associations. So nowadays, a lot of these associations, the genetic basis is being unraveled, like charge or factorial, where there's a combination of these features, which were earlier thought to, come together more often than would be expected by chance. But now you have genetics, which we know for charge syndrome and others. Then the biggest or largest group, wherein multiple abnormalities, if they are present, and their consistent recognizable pattern is present there, that is for which we have an underlying cause. That would be a syndrome. So multiple abnormalities with a recognizable pattern with a known underlying cause is syndrome. So obviously, when we're dealing with syndromes, as Dr. Naresh already mentioned, it could be at different levels. It can be the chromosomal syndrome, or a microdeletions or duplication syndrome, or a single gene syndrome. So obviously, when we are dealing with issues at the gross chromosome level, that would be a chromosomal syndrome like Down or Patau. When you open up the chromosome, it is a long thread. So if a large chunk of a thread is deleted, that would be a contiguous gene syndrome. And each rung of the thread here is the ATGC base pairs, which will be classified as single gene condition. So essentially, we have a battery of tests which are now available, like Dr. Naresh already mentioned, karyotype, FISH, arrays, and exome sequencing, etc. But obviously, we need to identify the syndrome just based on the evaluation, initial evaluation, and then decide on the test which we need to consider. So what would be the first line of genetic investigation that we would plan in a dysmorphic case? Though it's not a hard and fast rule. If it is multisystemic abnormality, like a cardiac abnormality, associated with intellectual disability, some antenatally detected issues, IVF conception, in the background of a previous bad obstetric history and no family history and possibly no consanguinity, you may consider microarray as a first-line test. Or nowadays, you can consider exome sequencing with what is called as copy number variant analysis, CNV analysis as well. But if you have a neurological involvement, brain anomalies, seizures, specific system abnormalities, like for example, you have cystic kidneys, consanguinity, or some previously affected SIBs, possibly you may have to opt for a whole exome evaluation as a first-line test. And then depending on each scenario, you may have to opt for a specific test like an MSMLPA for Prader-Willi or methylation study for a Beckwith-Wiedemann. Now, obviously, the simplest and commonest known syndrome is Down syndrome. But we have to be aware that in the neonatal period, the features could be more subtle. Obviously, as the age advances, it can get more prominent. And this is perhaps one of the indications to consider a karyotype as a first-line test. Similarly, two other conditions which are not frequently seen nowadays because of good antenatal scans, and most of these pregnancies are considered for discontinuation, but a Patau syndrome or an Edwards syndrome would classify when you can consider as a karyotype. When you see these typical features like a clenched fist with a rocker bottom foot, we would consider Edward as a test of choice here, karyotype as a test of choice. Similarly, Turner syndrome. Turner is not evident earlier in life, but sometimes in some neonates it can present as a pedal edema. Okay, and obviously as the child grows, it can present with a primary amenorrhea, a delayed or absent secondary sexual characteristics, short stature, and usually normal intelligence. Now, the next line test usually, or nowadays the test which would be considered as a test of choice for non-specific dysmorphism would be chromosomal microarray. What it does, it probes into the chromosomal regions, or subchromosomal regions, to look at deletions and duplications. So obviously now this child, you can observe the dysmorphic features, there's hypertelorism, you can see the hairy forehead, depressed nasal bridge, a flat tip, a long philtrum, scoliosis, see the abnormality in the ear. Obviously, multisystemic abnormality, non-consanguineous family, the microarray was considered, and that showed a deletion of 12 MB in chromosome 9q24. So because of microarray, it can probe the whole genome, that is all the chromosomes, and look at deletions and duplications. But when you have a pattern, like for example, some symptoms like Prader-Willi syndrome, at the point at which you look at, the features would be different. In a neonate, it would be more of a floppy infant. They would have feeding difficulties with low birth weight. And as the child grows, they would have the typical facies and the obesity patterns which would develop. And eventually they would have a degree of genital hypoplasia. So now we know that essentially the first test of earlier we used to consider fish, then microarray. But now the test of choice is what is called MSMLPA for Prader-Willi syndrome, which will pick up all the types of PWS, which will be microdeletions, the uniparental disomy, and for SNRPA gene mutations, obviously, you will have to consider exome evaluation. This will also pick up imprinting abnormalities. So MSMLPA would be a test of choice, obviously for Prader-Willi as well as Angelman syndrome over fish and microarray. Again, a classical syndrome which is identified by Jescott is a Williams syndrome. So you can see the periorbital puffiness, the fullness of the lips, the philtrum, and the typical behaviors based on which we would consider a diagnosis of Williams. Earlier, again, we used to do a microdeletion by fish. Now we would utilize a microarray to diagnose this condition as well. Now this particular child has abnormalities. There is a lot of dysmorphic features. There's bifrontal narrowing. You can see the straight eyebrows, a long philtrum, brachydactyly, and a significant intellectual disability with an IQ of 43 and a lot of behavioral issues. Now, again, this 1p36 deletion syndrome has come to have a face, and we can nowadays identify the child is walking into the OPD, and sometimes you will identify that this is a 1p36 deletion syndrome. Again, a microarray would be a test of choice in this case. Now, the particular child, this child had significant, you can see the myotonic or hypotonic face, the hypertelorism, there's ptosis there, the epicanthic folds are present, then there's a flat occiput. You can see the ear dysmorphic features as well. So obviously, when we did, the neck was very short and, a web. So we thought of a Turner syndrome-like phenotype first. She had significant short stature, but at the same time, she had a large VSD as well. So this turned out to be a condition called Jacobson syndrome, where there's an 11q24 microdeletion, which was again identified by a microarray. Now, do you see a pattern here? Now you can see the face, you can see the synophrys, see the second and third toe syndactyly, a single transverse crease with clinodactyly. So obviously, you have to observe for the pattern. And now you know this is a Cornelia-de Lange syndrome. Now, obviously, this is a single gene condition wherein the microarray would be normal, and you need to consider exome sequencing for this particular condition. So this kind of a pattern recognition. So it's not just one feature, but multiple features that we need to put together to identify a pattern. So that is what is called pattern recognition. So in the lower frame, you will see that this child has a dysmorphic face, tongue nodules are seen, a preaxial polydactyly of the toes, and a molar tooth sign. So sometimes you may have to consider internal investigations to give you clues. So this would turn out to be a Joubert syndrome. So obviously, the test of choice in these cases would be a next-gen sequencing. The first level usually would be a whole exome sequencing nowadays, and if negative, we may have to go for whole genome sequencing, which will look at a whole lot of other issues, which we will not be discussing obviously today. It's a completely new thing which is coming up, and many things could be detected by a whole genome. And what it would look at, obviously, it will look at the single base pair changes, that is called single nucleotide variation, and on using appropriate bioinformatics tools that would pick up various deletions and micro deletions and duplications as well. Now see the pattern over here. Again, you can see the child is significantly dysmorphic, a very coarse face, a bulbous nose, very thick lips, and obviously you can see the hands, very sparse dermatoglyphics, and the corpus callosum is absent. So looking at this pattern, you think of a possibility of a coffin serous, and when you do an exome sequencing, they showed an added P heterozygous de novo variation, which correlates with coffin serous. Obviously, when you're doing the first line of correlation, it should be an OMIM, when you need to the OMIM features to match with the phenotype to reach a conclusive diagnosis. So obviously, when you have this kind of a pattern, you could always type this into OMIM database. So here you have a child with dysmorphism, a post-axial polydactyly, along with an agenesis of corpus callosum. So obviously, this is not a coffin series, this is acrocallosis syndrome. So just putting these important features, which are called as phenotype handles, into the omen, that would help you in determining the syndrome. And now you have these apps which are available based on hot maps. You just click the picture and give it certain clues. Based on the hot map, it would really give you, it would take you close to the diagnosis. Obviously, but the phenotypes are evolving and you cannot expect it to be correct each time. So you have to filter a lot to really reach a correct diagnosis. You see the child again, so it's like you can see the dysmorphic features, you can see there's a 3rd-degree consanguinity. Now this child is showing significant features like there's a lot of wasting which is noted. You can see the dysmorphic features, but what is very significant is you can see the chin. It's quite rigorous. There's significant retrognathia, and if you look at the hands, you can see the terminal blunting of the fingers which is noted, which on X-ray has actually shown an acroosteolysis. So obviously now you're putting all these features together. So the importance to show this case is essentially along with the phenotypic features, you will need internal evaluations by X-rays, MRIs, and other features to really clinch a diagnosis, which turned out to be a mandibular acral dysplasia with lipodystrophy. Sometimes the diagnostic odyssey is not very simple. Now, this child was moving around for a diagnosis for many years. Around 8-9 years, the child brought in a cramp, had a global delay, profound intellectual disability, in MRCP-like presentation. She was very spastic. A lot of dysmorphic features were present. Obviously, you can see the microbrachycephaly, there were almond-shaped palpebral fissures, long eyelashes, and so on. And she was non-verbal, dystonic, dyskinetic, spastic quadriplegic. Now, she came with a karyotype, which was defined as an XY. So it was a karyotype, was an XY karyotype. Obviously, the genetic evaluation did not show any external gonads. There were no related structures which were noted. And the MRI showed a significant cerebellar atrophy. So they had done an exome evaluation earlier, and that did not, show a definitive diagnosis. Then we did a microarray which was normal, and ultimately on data reevaluation, it turned out to be a pontocerebellar hypoplasia type 7. It's related to TOP1 gene. So obviously, this is a rare combination of a pontocerebellar hypoplasia with a disorder of sexual development, and it's most apparent in the XY phenotype. So because there's a complete undervisualization, which can range from female genitalia, like in this case, to a child having a micropenis or a hypoplastic scrotum. So the diagnostic odyssey sometimes can go for many years, because this child was diagnosed to have this XY, but the gene was not identified. And once this gene was identified, we could pick up on the exome reanalysis. Sometimes some simple cases like Fragile X, obviously you cannot use an exome, it should not be picked up. You have a face, but that face evolves over time. So you do not, in a child who's of 6 or 7 years, you may not have that typical triangular faces or a relative macroscope that usually would develop later in life. So you have to have a high degree of suspicion looking at other features as well before coming to a conclusion regarding the investigations. There can be a lot of metabolic phenotypes. Here you can see a case of congenital hypothyroidism presenting with a coarse face. And the one below is a mucolipidosis, wherein any child who is born with an MPS-like face is unlikely to be an MPS. It is more likely to be mucolipidosis. Similarly, MPS children, initially they would look normal, and as they grow in age, they would have these dysmorphic features. The panel on the right shows a child with homocystinuria, and the one below is a macrocephalic child, a case of glutaric acidemia type 1. So metabolic disorders also would have their phenotype. Now, sometimes these, the dysmorphic features can be limited to a specific area. Like in this child of Treacher-Collins syndrome, obviously it's just neck upwards that there will be significant dysmorphism. Otherwise, they're completely normal. Similarly, Dr. Tyree mentioned about Beckwith-Whiteman syndrome. It's one of the phenotypes which you can identify just by looking at the child. And it's not diagnosed by exome sequencing. We require methylation studies for the diagnosis. And in some cases, though a lot of dysmorphism is present, there is no genetic diagnosis in these cases, like Proteus syndrome or Thiepel-Trenaunay syndrome, wherein though we are finding a lot of physical features which are classical of that syndrome, the genetic basis is something more at a somatic level. So you need to consider biopsy specimens to really reach some conclusion, but most of the cases you will not have any diagnosis. So how do you evaluate a dysmorphic case? So obviously you're taking a history, you're noting the dysmorphic features meticulously from head to toe. You have to address the child and look at the skin, the genitalia, and all the parts to really come to a conclusion. Like, for example, sometimes just abnormal part of fat at the chest and the buttocks can give you a hint that it could be a case of a congenital disorder of glycosylation. Always photograph the patient so that based on the photograph, you can utilize these, the AI tools to come to a conclusion. You can search various dysmorphology databases. You have to examine the parents always for minor variants. A thorough systemic evaluation is crucial, and you need to investigate, a few steps before you really plan a genetic testing. So, important investigations in dysmorphology will include skeletal surveys, the USG of abdomen, a KUB, neuroimaging, and sometimes some basic profiles like calcium, hemogram, thyroid give you clues as to what condition we are dealing with. So why do we need a diagnosis of dysmorphic cases? We need to offer specific genetic counseling. You need to answer queries regarding the prognosis or discuss the risks of recurrence for the future pregnancies so that you can identify, even if it's a syndrome, you can identify the potential strengths and weaknesses and then direct the further reference. So obviously, what are the inheritance patterns? But that will largely depend on the genetic etiology that is identified. So chromosomal aneuploidies, microdeletion syndromes, they are sporadic, so they have low risk of recurrence. While if it's a monogenic syndromes, they can vary from recessive condition to be 25% to certain classic dominant condition to be 50%. And obviously, parents would want a prenatal testing, which can be appropriately offered based on the investigation done in the index child. Now we'll quickly move on the last few slides to newborn genomics. So obviously, Dr. Phadke madam just mentioned about newborn genomics, very, very crucial for symptomatic neonates and stillborn babies. But what is the question about asymptomatic neonates, or what we call as genomic NBS is the question. So obviously, any child, baby who's born, this particular baby in the antenatal period only had significant issues and a poor prognosis was explained. And the baby died, within a few hours. What is crucial here? Obviously, you can see the dysmorphic features. 2 children have died. The previous baby, 2 died with a similar issue. And you can see the classical dysmorphic features. So one is you're taking a proper photograph. You're collecting the samples appropriately for genomic testing. If the family is not affording at that time, at least a DNA storage, which is called DNA banking, is crucial. Very, very important to note down the dysmorphic features and also document some other investigations like some X-rays or scans or 2D echo if possible can be done before the baby is handed over. So obviously these cases, like looking now the baby who was born, this was looking very much like a storage disorder like condition. A puffed up baby was born, it was stillborn. So though it is stillborn, it is very, very crucial to undertake investigations, to identify an etiology, which is going to help the parents in their next pregnancy. Now, this particular baby, again, taken to the NIC, had significant issues, had, a congenital heart defect, hypotonia, neonatal seizures. There were renal cysts with hepatomegaly, and an MRI that showed pachygyria with nodular heterotopia. You can see the classic dysmorphic features, akin Down syndrome. So obviously, this is what is called as a Zellweger syndrome, and you need to reach a genetic diagnosis. So if it is possible, undertake a biochemical diagnosis, but at least DNA storage followed by genomic diagnosis is crucial, because though the child may not be saved, but it is mainly for their next pregnancy. Now the question of genomic newborn screening, that is screening in normal newborns. We know the Wilson and Youngner criteria, which are classical screening criteria. So one, it should be a health problem, there should be a treatment available, there should be a proper facility, to manage those cases. The test should be acceptable to the population. The overall natural history of that condition should have been understood. And obviously, there should be a suitable test which is available. So obviously, does genomic newborn screening really conform to these Wilson and Younger criteria? Now I'll just take you through these simple examples. Now all these variants were identified in normal neonates. The first one is the NUFAF variant, which is a compound heterozygous, a likely pathogenic and a worse variant which was reported, and it's segregated in different parents. The newborn is completely normal, and this phenotype is a complex one deficiency which can lead to severe neurological issues going ahead. The second one was a fucosidosis case, wherein again, obviously the homozygous variant was identified in the normal neonate, but luckily we have the fucosidase enzyme which is available. We test that enzyme and tell them that the baby is not affected. But what about the mitochondrial complex 1 deficiency or the third case, the trio variant? So the pathogenic variant was identified in index child. It was present in the unaffected father. So obviously, though we could reassure to some extent that this is not likely to lead to major issues, but we know that a lot of variable expressivity and reduced penetrance of this gene is known. So absolutely normal in neonates, how do we interpret these conditions and how do we guide the parents? So a lot of ethical dilemmas and points to ponder rather than giving us answers. So how do we interpret these reports in unaffected individuals? Do we really have a treatment for these disorders? If picked up early, possibly fucosidosis, you can consider a bone marrow transplant. But we really don't have treatment. What about the anxiety that we are introducing in the parents, going into the future? Can they really enjoy their parenthood? The associated of stigma of being carrier of some variants which have not been proven to cause a disease. How do you approach late onset conditions? Does it really justify the cause? So the question is, are we really ready for a genomic NPS in a country where the basic 4 parameter screening is also not being considered? Are we really ready for the genomic NPS? And possibly, Madam could answer as about the president of SIMG. Can we have certain guidelines for SIMG for case selection for genomic NPS, which is now becoming sometimes rampant to an extent in the metro cities at least, so it's becoming fashion to really consider a genomic NPS. But a lot of things really points to ponder whether it is really justified in doing this test at this stage, where we have yet to know a lot about genomics as such. So with that, I would end and I would await Madam's comments on the GNPS especially. Thank you so much.
Yeah, Dr. Chaitanya has very wonderfully covered in details, very complex topic. And this dysmorphology, I think many pediatricians are interested and were interested for many, I think, last decades. Initially, myself being from pediatrics background, and the metabolic testings were not available maybe 3 decades ago. So we used to be more interested in dysmorphology diagnosis, which was considered like a puzzle solving. You identify various features and then put them together and get a diagnosis. But from that time, the things have changed a lot. First thing is that metabolic disorders and dysmorphology are not watertight compartments. As Dr. Chaitanya showed, many storage disorders, Zellweger syndrome, and including polycystic kidneys can be a feature of a glutaric aciduria, multicystic dysplastic kidneys. So they are not really watertight compartments. Secondly, the dysmorphology diagnosis is initially was we can't do anything for them. We just make a diagnosis and probably more of interest to the pediatricians than the parents. But now we know that lot we can help the families in many ways. Sometimes, like if they bring the child for short stature, you make a diagnosis of Larsen syndrome where there is joint laxity, and you tell and investigate and find that the child has a atlantoaxial instability, and you get a preventive surgery done, which is life saving. So, such are examples how we can directly help the patient. It's not that we cannot help. And sometimes the prognosis, like we have seen some ventriculomegaly is operated where we know that it's not obstructive ventriculomegaly. So, good prognostication and, of course, a better prenatal diagnosis and prevention. For that, the diagnosis is very important. And the first and foremost, even in the NGS era, is the clinical examination. So, those who are interested probably should see that dysmorphology issue of American Journal of Medical Genetics. And now, with this information which Dr. Chaitanya has said, it's only direction he has shown. So, everybody, every case you see, you work on it day and night, and you get a diagnosis, and that's how one can improve the dysmorphology diagnosis and try to help the patients and families. But the family history and recurrence doesn't always mean genetic. So there are teratogenic disorders that can recur, even if it's a genetic disorders, not that every recurrence is autosomal recessive. There can be chromosomal. So we want that one test you do genome sequencing and identify all disorders. But that is still we are far away from that. But appropriate testing can be done. Appropriate clinical examinations continues to remain mainstay. And in this case, dysmorphology, the clinical examination has to be done with a great sensitivity, because face is uh, our identity. And the parents, like, even if the child is not able to understand, but if you use in front of parents something like ears dysmorphic hai and so many things, so that is not a correct thing, because the parents may not like to be such discussion in front of them. So I have to tell the residents, don't speak anything in front of the parents. And then when you examine carefully, but without making the child or parents conscious of it, don't say that the ears are similar to father and it appears to be familial feature. So no comments. And this is a very, very important thing everybody should remember. And that's why I felt that this word is little not very it's not very it has a very important history. Dr. Smith, David Smith, coined the word dysmorphology, and that describes everything. But now we don't want to say mental retardation. We want specially gifted children or intellectual disabilities. Same way Divyang we say for disabilities, and then that's why I said the word Swarupology, which I wrote in an article in American Journal of Medical Genetics. That article, different dysmorphologists have written small pieces, and everybody has said his or her vision for dysmorphology in the next decade. And that article probably Dr. Chaitanya can share with the and then it's worth reading. One more point I wanted to tell, which Dr. Chaitanya has already said, examination of stillborns. So many pediatrician neonatologists go to attend the deliveries. But if the child is stillborn, then probably there may be debate, discussion amongst the obstetrician and pediatrician, and then they leave. But if the child is not born alive, it's more important that pediatrician examines. And of course, autopsy has to be done. But even if autopsy is done by a pathologist, some clinician who has an idea about dysmorphology should examine, take photographs, and we can make many real diagnosis of stillbirths, and that would help the pediatrician and obstetrician to get away from the blame of getting that label of that the perinatal care was not correct. So many times even congenital muscular disorders, they just can lead to sudden immediately death after birth, because in abdomen they don't, in uterus they don't need any muscle movement, but as soon as child is born cannot take respiration. So there are many such situations, and one has to keep on learning more and more about dysmorphology. But of course, the diagnosis is a challenge. Even in the NGS era, we can make only diagnosis in 40-50% of cases. But I would always tell everybody, please don't make a hurry to give a specific label. Even with NGS, if the variant is not very definitely pathogenic, then please don't give the label, because once you say that this is a Robinson-Tabby syndrome or this is a Cornelia de Lange, and then everybody he goes and the child gets the same label, while the disorder may be different. So it's a very challenge in this powerful NGS era. The diagnosis is difficult. Lastly, if just Dr. Chaitanya's last question about NGS for newborn babies. So this is I have one clear message for all pediatricians. For newborn screening, all possible other method, TMS and traditional ways of newborn screening, are essential and should be done or must in this current era. But NGS based, exome sequencing based newborn screening should be done only in the research settings. No, should never be done for any patients. What he has shown that it can lead to so many dilemmas, mislabeling everything. To this, the one reason I would add about two important papers now, where they have seen data of lakhs of normal individuals and found that so many had genes for retinitis pigmentosa mutations, but only 20% had the disease. That means what we know from the data of patients which we are seeing, we really don't know what that variant will do in normal individual. So our genetic clinics, this 1st July issue which will come has these three important articles, summaries in gene reviews, and they have shown that penetrance of many definitely pathogenic mutations is very low, 10 to 15 to 20% at the most. So if you the baby doesn't have any symptoms, and if you test genome and you get some variation of a very serious disease, we don't know what we will do. We tell parents we don't know what to do with this. Parents will then say, why did you test it? And they may become very anxious, and lot of miss things can happen. So please, no newborn screening based on NGS in normal neonates at this point, except if it is under research settings, where the giving consent would be a matter of 1 hour, at least, to let them understand what has to be done. So that is all from my side. And it's a really good talk, lot of things covered, and mainly the very nice pictures. Thank you, Dr. Chaitanya.
Thank you, Dr. Datar sir and madam, for very simplified approach about diagnosing dysmorphic child and highlighting the importance of head-to-toe examination, dysmorphology, and phenotype in picking up various genetic testing, and also highlighting the concept of newborn genomic newborn screening to all the pediatrician. Thank you, sir. Now we proceed to our third and final scientific presentation. I invite Dr. Suvarna Magar madam to start with her session of inborn error of metabolism and journey from metabolomics to genomics. Over to you, madam.
Thank you, sir. Are my slides visible?
Yes,
Is my
ma'am.
screen visible?
Yes, yes. Kindly make it full screen.
At the outset, I'm very thankful to Dr. Sanjeev Joshi, sir, Dr. Renu Gorakar, ma'am, Dr. Praveen Gokhale, sir, for giving me this opportunity to present on my MahaIP platform. Here I start with the presentation of my favorite topic, inborn errors of metabolism. So in 1908, Dr. Archibald Gerard first time announced the existence of inherited metabolic disorders with the first publication of 4 disorders. And today in 2020, we have 1,450 inherited metabolic disorders, and the list is ever increasing. So what are IEMs? So if you see, every cell in our body has hundreds and thousands of chemical reactions occurring, and because they are all in sync, we as a human being or all the living beings are fully functional. So what happens whenever there is inborn error of metabolism is due to inherited disorders due to mutation in the DNA, which codes for the specific protein leading to deficiency of an enzyme, transporter, or cofactor in a metabolic pathway in a chemical reaction. So there is a substrate which is catalyzed by enzyme to form a product. Whenever this enzyme is deficient because of the mutation in the DNA or pathogenic variation in the DNA, we have a substrate which accumulates in the toxic amount. We have a product which is deficient, and the substrate being available in plenty, it is diverted to different pathways and also in the secondary pathways. So all of these chemicals will cause certain set of symptoms and signs, and which we call them as inborn errors of metabolism. Broadly, we have three macromolecules, the carbohydrates, proteins, and fats. The carbohydrates are converted to glucose, and then glucose is finally converted to acetyl coenzyme A. The free fatty acids are again undergo beta oxidation and converted to acetyl CoA, and proteins are degraded into amino acids, which may be glucogenic or ketogenic, both of which forming acetyl CoA, and that enters into the mitochondria for TCA or Krebs cycle, and then finally ATP generation in the mitochondria. So, and otherwise, these chemicals are being used for structure formation of all the cells and the entire organ systems, tissues, etc. So this is how the system is working in milieu. So broadly, previously we classified IEMs as a small molecule disorders or a large molecule diseases. Small molecules being these molecules which are water soluble, and they have predominant neurotoxicity, hepatic toxicity, etc. And acute presentations, disorders like disorders of carbohydrate, proteins, fatty acids, vitamins, etc. And whereas the large molecules are the complex molecules where they are formed between two macromolecules like a glycoprotein or a lipoprotein, something like that. And they predominantly present as a chronic long-standing disorders. And these are the complex or macromolecules which are deposited in various organs and causing certain set of typical features. We call, for example, lysosomal storage disorders or peroxisomal disorders. Currently, recently, this ICIMD has classified now on the similar lines the small molecule instead of large molecule as complex molecule, and energy defects, which are defects in the mitochondrial fatty acid oxidation, and also glucose transporters as a part of energy defect. So there are these three classifications for this 1450 disorders in the recent times. So the challenges, the IEM diagnosis is very challenging for the clinicians. That's because there are very vague symptoms. Every time they mimic with the sepsis, hypoxic ischemic encephalopathy, and encephalitis. The number of disorders are ever increasing. It's very difficult to remember them. Single disorder has variable presentation as different ages, different type of clinical and metabolic abnormalities, again making it difficult to recognize. They are very complex, multi-organ involvement is present. So again, difficult to diagnose, always confused with rheumatological or immunological and many other things. Emergency management is one thing, and further treatment, how to be done, that is all remains a very challenging task for clinicians. Simply how to counsel for sending metabolic test, and how to counsel when the reports arrive. So that's one of the very challenging situation for pediatricians. So we do not feel confident about sending the test, and what do I tell to the parents once the test come positive, or how do we interpret them? So there's also this lack of expertise for interpreting metabolic reports, and that makes it very challenging. So this is a video of a most common presentation of IEM. This is a full-term male child, 3.2 kg. He required some stimulation for breathing at birth, a common scenario, and we immediately label this as hypoxic ischemic encephalopathy. So this baby was fine till 24 hours of age when he started having refusal to feed. And this video is at 36 hours inside the NICU, where we can see the baby is deeply having altered sensorium, encephalopathic, and having focal seizures. So whenever there is no clear-cut history of hypoxic perinatal asphyxia or delayed cry as such, we need to be very vigilant. And this is the commonest scenario. We must be picking up such babies in the neonatal age itself to prevent the further morbidity and mortality. So when to suspect IEMs? So the severely ill infant and neonate and in early infancy, there are very non-specific features like poor feeding, irritability, drowsiness or altered sensorium, seizures, failure to thrive, hypotonia. So during the neonatal stay, again, I will reiterate, high index of suspicion is required in all the sick infants alongside of sepsis, HIE and congenital infections. Apart from the common presentation of encephalopathy, there can be acute liver failure, acute renal failure, unexplained persistent metabolic acidosis, persistent hypoglycemia, vomiting, etc. can also indicate underlying inborn error of metabolism. So apart from this acute presentation of IEMs, there are also presentations which go for a longer time, like chronic presentations. Simply a child with a global developmental delay, usually without dysmorphism, can also be a small molecule IEM. Failure to thrive. There is increasing organomegaly, recurrent infections. There are certain skeletal changes, not gaining height, which can indicate towards a possibility of IEM. And there are certain very specific unique feature which can be a diagnostic handle to conditions like cataract in galactosemia if associated with liver failure, lens dislocation with intellectual disability, can be hyperhomocystinemia, mousy order to the urine in the setting of global delay, can be a phenylketonuria, and other things like presence of consanguinity because autosomal recessive risk disorder risk is increased in case of the consanguinity. Also note down the family history of deaths or pregnancy losses. So 3-generation pedigree charting will definitely give you some idea about possibility of a inborn error of metabolism running in a family. Move on to the first case. This is a 8 days old girl admitted with decreased feeding and lethargy. So at birth, the baby is absolutely fine, 2.6 kg, full-term delivery, accepting breastfeeding well initially. But on 8th day, baby rapidly, this was the day of admission. What we can see, the baby is having altered sensorium. There is frothing at mouth and continuously seizure activity was going on. Again, a born of consanguineous and the first child in the parents. So let's take the break from the case and we will learn about this common scenario of encephalopathy and how we should go about further. So we have to rule out the sepsis in any case, so that one of the common and treatable condition and this child, the CRP was negative, CVC was unremarkable, and this makes the situation more towards the inborn error of metabolism. And also not to forget that sepsis can also be one of the presenting feature of IEM, similarly like galactosemia can present as E. coli sepsis. So this GLAT test is a primary metabolic screening, which is very important. Together, the cost of this 5 investigation will just be 2,000 to 3,000 rupees, and in today's time, they are not at all costly. So any encephalopathy patient where the cause is unclear, we must do the glucose, look for hypoglycemia, hyperglycemia, increased lactate, ammonia levels, acid-base status with metabolic acidosis, and presence of ketones in the urine. These 5 tests are window to the diagnosis towards the IEM. So this is just a table which will just tell you about possibility of which kind of IEM we are dealing with. When this urine ketone has massive ketonuria and we cannot find any acidosis or increased lactate ammonia, we're dealing with the maple syrup urine disease. If we see that there is everything is present, lactate may or may not be much elevated, but we have very high ammonia, high massive ketonuria and acidosis, we know it's an organic aciduria group. When again there are everything is present, ammonia may or may not be elevated, but lactate, ketones, acidosis is present, lactic acidosis, mitochondrial disorders, especially the fatty acid oxidation disorders can be hypoketotic or non-ketotic. That means the ketone bodies may be absent. So that we must remember that metabolic acidosis with absent or very small quantity of ketones. And then ammonia, only ammonia is increased is a window to the urea cycle disorder. So simply any encephalopathy child, this ammonia test becomes very important, because if that is elevated, you have a direct suspicion of a urea cycle disorder. And even if all the tests are negative, there can be still possibility of various inborn errors of metabolism. And again, we have to do further testing. So investigations in the first case where blood sugars were normal, the arterial blood gas showed respiratory alkalosis, serum lactate was in the normal range, ammonia for 50 microgram per DL, it was 680 microgram. So and urine ketones were negative. So what we have a situation of only ammonia elevated, and this is, as I said, it's a window to diagnosis of urea cycle disorders. So this baby is a full-term good birth weight female infant on breastfeeding, presentation with encephalopathy, severe hyperammonemia. So severe hyperammonemia, if there is no acidosis or no metabolic alkalosis, but here there is a respiratory alkalosis, urea cycle disorder, we have to send plasma amino acids, and next test we have to do like tandem mass spectrometry and GCMS and urinorotic acids. And if hyperammonemia is present with acidosis, again from the table we can make out this can be underlying organic acidemia, mitochondrial disorders, or fatty acid oxidation disorders. So this is again those 5 enzymes in the urea cycle disorders which we can diagnose based on the TMS and urine GCMS. I will not go into the detail. So very important practical aspect is which precautions to be observed while collecting the samples here. So whenever we want to send the ammonia levels and lactate, what we need to do? The ammonia is 2 ml arterial or venous sample. We have to collect it like a free flowing sample, ideally in a pre-heparinized syringe, transported on ice immediately, and it should be analyzed within 15 minutes. Similarly, for lactate, it has to be in the 2 ml blood in the fluoride bulb, not to be force blood in the tube, no squeezing. And it again transported on ice immediately and analyzed within 30 minutes. Urine ketones or urine keto acids by DNPH method, freshly voided urine is checked. And you can do the dipstick and on bedside, but it does not detect the beta hydroxybutyrate, the additional ketones. We have to have the urine GCMS test for the same. So this is the filter paper sampling being done, where we must have seen this in NICU or PICU. You must have sent for the newborn screening or even tandem mass spectrometry in the ICU. So this second line test needs to be sent, and this is on the special filter paper. So once we have a primary metabolic screening suggestive of some abnormality, we have to do tandem mass spectrometry. So what is this test? It covers 12 to 15 amino acids out of the 20 amino acids, and it can detect semi-quantitatively the levels of these various amino acids. It can also detect the total and free carnitine level, which is a mitochondrial, which is a transporter molecule for fatty acids, and acyl carnitine, where these fatty acids are metabolite with the carnitine. So these metabolites are identified by TMS, the method in which the ionic charge and the atomic weight is taken into consideration to identify each molecule. Serum homocysteine has to be done separately. And apart from that, CSF amino acids and CSF neurotransmitters, also plasma amino acids, fully quantitative test can also be done by HPLC. And lastly, urine for organic acids by gas chromatography and mass spectrometry. All these tests are gold standard and for diagnosis of many of the inborn errors of metabolism. So after primary metabolic screening, these tests become very important for getting the diagnosis of treatable disorders in IEM. So urine organic acids, if you do not have a filter paper immediately, we can save the 20 ml of urine without preservative in the airtight container and kept in the freezer. If it's a filter paper, it has to be air dried completely. Contamination should be avoided and kept at the -20 degree DNA. Plasma amino acids can be preserved in EDTA or heparin sample, and fully quantitative HPLC is better, but costlier, but at least on the filter paper we can take. Acyl carnitines we can check on the similarly on the TMS paper. So I counsel the parent for the further line of test, because this ammonia was very high. Side by side started on the treatment. We send the TMS, and what we can see, the citrulline value for a cutoff of 93, it is 2250, and citrulline by arginine ratio of 477. So exome showed, of course, this is a classical citrullinemia type 1. The diagnosis is based on the TMS and GCMS itself. We could not send the GCMS, but TMS was very much typical of this citrullinemia, and we proceeded with the treatment of this child. So we also confirm this with additional testing of exome with homozygous likely pathogenic variant in the ASS1 gene causing classical citrullinemia type 1. So what happened is this baby expired in 48 hours. Parents were not affording, and because we had sent the TMS with lot of difficulty, we counsel the parents about the DNA banking. And the very important step here for all of us is whenever there is an encephalopathy, a impending death, or any situation, suspected IM, please send the TMS. At least the genetic lab will have, or the metabolic lab will have the filter paper, and where DNA can be extracted or can be saved as in the DNA banking with the genetic lab. So we have the DNA sample retrieved from the baby itself. So that becomes a very important step for the further confirmation of the diagnosis. So we got the diagnosis for this baby and was used in the next pregnancy. Another important situation when the diagnosis of IM is suspected, by the time we suspect, the death becomes inevitable and we really do not have certainty where we are leading. So we must counsel about that. We are suspecting some metabolic disorder, inherited metabolic disorders, and we can collect sample 5 to 10 ml of blood frozen in EDTA for DNA studies. If required chromosomal studies, then we can save for heparinase sample. Urine and CSF is saved at -20 degree. Various biopsy samples can be taken like skin, liver, heart and kidney based on the situation. One must take the clinical photographs and infantogram if there are skeletal abnormalities, and then later on we can work upon the case. So we'll not go into the detail of treatment of hyperammonemia, but whenever we suspect a child with inborn error of metabolism in encephalopathy, first thing is stop all the feeds, stop all the extra protein sources going to the child. So nil by mouth for at least 24 to 48 hours is a very important first step. Second is providing extra calories with dextrose 10% glucose and maintenance electrolytes. One may add intralipids, but amino acid should be avoided on the first 1 or 2 days because we want the glucose to be used as the cheap source of energy and not from the other sources of protein or other metabolites causing further increase in the problems to the baby. So D10% and maintenance electrolyte will be very important. And for hyperammonemia, there are this sodium benzoate, sodium phenyl acetate, arginine hydrochloride are available. We can give that in the loading dose as well as maintenance dose. And if 48 hours, if there is not much improvement, we can go ahead with the peritoneal dialysis. Second case is a 24-day-old boy born of consanguineous marriage, and he manifested decreased activity lethargy since birth. And just 1 day prior to the admission, baby had multiple episodes of convulsions. There was tonic posturing inside the ICU also. There were feeding difficulties. On examination, abnormal shallow breathing was seen, and baby had not gained weight, regained the birth weight also, and the baby had encephalopathy. So as we suspected IEM, we first did the primary metabolic screening. The sugar was 75, pH of 7.02, bicarb was 6. So there is a severe metabolic acidosis. The urine ketones in the bedside was 3+, serum ammonia of 104 micromoles per liter, serum lactate 2.5 more than 1.9 was abnormal. So we here have everything abnormal. The metabolic acidosis, urine ketones, hyperammonemia, hyperlactatemia, and MRI brain was done, which suggested bilateral basal ganglia hyperintensities. So this is a very typical picture of organic acidemias. And so we have a metabolic acidosis, increased anion gap. We have to deal with the find out about the organic acidemias. We have to send the amino acid by TMS and urine organic acids. So here we send the tandem mass spectrometry, and in the acyl carnate, the amino acid profile on the right side is normal. But the TMS suggested increase in the C3, and also the ratio of C3 by C2 was elevated. So there were possible differentials given. So don't worry about the TMS result. Usually the lab will give based on the metabolic profile identified whether of the increased metabolites or decrease. They also give us the differential diagnosis. We can go and read about them further. So here there were 3 differentials: propionic acidemia, methylmalonic acidemia, and vitamin B12 deficiency. Again, one of the very mimicker in this age for all kinds of disorders. So here we need a further confirmation with the urine GCMS, and this was the urine GCMS test where the number 5 methylmalonic acid was it was 1311 times elevated, very sky high elevated. So this was a methylmalonic acid elevation, and then confirming or coming down to a single diagnosis of methylmalonic acidemia. So methylmalonic acidemia has many subtypes, and that is why the genetic test here becomes important. For the inborn error of metabolism, exome sequencing or next generation sequencing technology becomes the most important diagnostic modality. This baby was diagnosed with the homozygous pathogenic variant in the MMA-CHC gene at codon 331, cytosine changed to thymidine, and it was causing a typical CBLC type of MMA. And the prognosis of each type of MMA depends on which gene is involved, and that's why it becomes very important here to also have the genetic diagnosis, apart from important for prenatal testing in next pregnancy. So how to manage? Again, the NBM, IV glucose 10% with maintenance electrolytes. Carnitine supplementation becomes important. Treatment of acidosis with soda bicarb is important. We can start with, when the diagnosis is unclear, we can start also vitamin B12, especially the hydroxycobalamin 1 to 2 milligram per day is very important, which should be given every day, can cause a rapid recovery. And if hyperammonia, treated on the hyperammonemia lines. Sometimes the diagnosis is unclear. We can start with the mitochondrial cocktail that various vitamins like biotin, riboflavin, thiamine, and pyridoxine can also be added because we do not want to take any chances for the neuromorbidity. So this baby was gradually shifted on the propionic acidemia MMA-PA2 diet, which is an indigenous company and the diet made by the metabolic dietitian from KEM Hospital. So who gives a very regular online consultation. So we have to find out about the metabolic dietitians also, and then channelize the treatment even after the at home. Next case is a 4-month-old male child born of third-degree consanguinity. Now this patient has a chronic presentation like a global developmental delay with arching episodes. So this baby was admitted in NICU on day 2 of life for refusal to feeds and lethargy. But he was labeled as sepsis and sent home on day 7 of life. This baby had light pigmented skin and hair as compared to the parents, and there was microcephaly, hypertonia, brisk reflexes, and we can see there was not much dysmorphism. So basic metabolic workup of GLAC was negative. So still we suspected the inborn error of metabolism because there was not much dysmorphism. So we were not suspecting a dysmorphic syndrome, but rather the neurometabolic syndrome. So MRI brain definitely one of the important investigation, but it just showed non-specific changes. And then we send the TMS, which showed phenylalanine of 1896 for a upper limit of 105. So this is straight away a case of hyperphenylalanemia, and pH tyrosine ratio was very high. And again, the urine organic acid had various phenylalanine metabolites, confirming the diagnosis of hyperphenylalanemia. We have to do further urine terine assay because tetrahydrobiopterin is a cofactor for phenylalanine conversion to tyrosine, and there can be various enzymes which can cause to hyperphenylalanemia and not just classic PKU. So this here again the genetic diagnosis becomes very important because again for the prognostication, for the proper treatment plan, terine assay may not be available easily, and terine assay cost is almost equivalent to the exome cost. So it was a BH4 deficient phenylalanine, hyperphenylalanemia, which requires folinic acid, L-DOPA, L-tryptophan apart from PKU diet, carnitine supplements, etc. And this baby was followed up later. They lost to follow up. We can see the various levels of pH levels being monitored at various intervals. They were very infrequent intervals, so we can understand the cost of treatment, the follow-up. Everything was very difficult because also though there was some improvement, but the child remained globally developmentally delayed because this was a severe kind of hyperphenylanemia. So this was the diet, PKU diet, which was available. We asked for the Kuan supplement from the NPRD, but this was not available, which could have changed the trajectory of his clinical presentation significantly. Moving towards last case, second last case. So this baby, I have put on my notes especially. So this 3 weeks old baby's was done, exome was done. This baby was normal at birth, and second, third day he developed multiple episode of convulsion and drug refractory epilepsy. On day 15, the baby, day 15, 20, the baby's MRI was done, which already suggested cystic encephalomalacia with corpus callosal agenesis. So corpus callosal agenesis is a congenital abnormality, but this cystic encephalomalacia was labeled due to secondary to HI. So when these parents came to me, they were labeled as going towards CP, or this is sequelae of HI. And we had highly suspected this HI mimic condition as molybdenum cofactor deficiency. So there was not at all a history of baby requiring resuscitation or perinatal asphyxia. There was no issues during the delivery time, but day 2, the child had become very sick. So this exome of the baby showed homozygous likely pathogenic variant in the MOCS2 gene, confirming molybdenum cofactor deficiency. So these in the NICU, we must consider the HI mimic conditions where there is no clear-cut history of requiring resuscitation or a bad perinatal history. We must consider that am I dealing with one of those conditions. And in brain MRI, acute findings are like HI, and chronic changes are cystic encephalomalacia. So these are very typically of the HI. Other conditions which can mimic HI are pyridoxine responsive epilepsy, folinic acid responsive epilepsy, non-ketotic hyperglycinemia, mitochondrial DNA depletion disorders, and GLUT1 deficiency. So there are so many, and the list is increasing. So we have to be very vigilant that we must remember, and some of the disorders like pyridoxine and folinic acid responsive, they respond well to the treatment. So we are giving trials to such babies who are drug refractory status, etc. But we need to further go ahead with the genetic testing in this case. And this is the last case. This was a 5-year-old boy with bony deformities and having recurrent respiratory infections, operated for hernia, and having some pore species. This baby also had hepatosplenomegaly, kyphoscoliosis, and was eventually diagnosed as a attenuated mucopolysaccharidosis 1. So this baby was referred to the KEM hospital for registration under National Policy for Rare Diseases, and under that he received enzyme replacement therapy prior to the hematopoietic stem cell transplant and post transplant also. And this baby is now, after 2 years also, he's doing well. His skeletal changes have resolved. He did not have much of mental affection, so he's intellectually normal, and his overall skeletal features, the hepatosplenomegaly, has disappeared. So this is very rewarding thing for this large molecule disorder or a complex molecule disorder, that we could do it under National Policy for Rare Diseases. Then I come to the last part of the slides. This very important from the Government of India is a National Policy for Rare Diseases, where the treatment is provided, where we diagnose the patients early with newborn screening or genetic testing. The patient is referred to the Center of Excellence where they are registered, and the further management plan is given, and rupees 50 lakh are sanctioned for patient for per year for whatever treatment is required, and the support is given. So this has been going on since last 5 years, and these are the group of disorders. Group 1, where one-time curative treatment is available. Another patient diagnosed at MGM with tyrosinemia has undergone liver transplant and is absolutely doing well. It has been 5 months post liver transplant. So there are conditions where we require bone marrow transplant, renal and hepatic. These is the group 1 disorders. Group 2 disorders where there is long-term treatment like metabolic diets in galactosemia, PKU we saw, MSUD, etc. And group 3 disorders where there are lifelong expensive treatments like Duchenne muscular dystrophy, other LSD, cystic fibrosis, etc. So we have to refer these children in timely to the NPRD Center of Excellence for proper treatment. And these are various Center of Excellence in India currently. They're doing a great work of enrolling these patients, keeping a patient registry. And that is all because we all pediatricians are referring to the center. So we have a real-time data of actually what treatment is being given and how many number of patients have been referred, etc. Lastly, on prevention, prenatal testing in a confirmed case is very important by chorionic villus sampling or amniocentesis based on the choice of the parents. This is my present article published on various IMs from Marathwada. And take home message lastly, IMs are not uncommon. Many IMs are treatable, not to lose hope as a pediatrician. Primary and secondary metabolic tests done at the time of crisis will maximum the diagnostic possibility of IMs. Very important to remember in a inadvertent situation, DNA banking can always be done in 1,000 to 2,000 rupees. And genetic test can be done later. Genetic testing is required for prenatal diagnosis in future pregnancy for confirmation of diagnosis in few situations. The diagnosis poor management will prevent morbidity and mortality in these patients. And refer to Center of Excellence for registration. Financial support to the patient under the NPRD is the most important step in today's time, so that we convey more and more such patients to the Government of India, and we have increased financial support towards the research and also management of these patients. Thank you.
Thank you, Dr. Suvarna.
Yes.
very informative talk. I think all neonatologists must be benefited by your talk. A lot of important things. But here I
Yes,
would
ma'am.
like to tell everybody that what she has highlighted, that the inborn errors of metabolism should be suspected at very early threshold. And the message is septicemia, cerebral palsy, birth asphyxia. These diagnoses should not be taken as diagnosis. In fact, previously we used to consider that if MRI shows cystic changes, that is definitely birth asphyxia. But what she presented a case that molybdenum cofactor deficiency, the cysts are there in first few days, and they look like HIE. So no diagnosis of HIE for these cases. And these are treatable even for molybdenum cofactor deficiency. The drug is available. So Dr. I.C. Verma sir, I remember his words. His always message was not to miss a treatable disorders. He used to say that will be misfortune not only for the patient, for also the doctor. So the time has come that you need to suspect, and there are many good neonatologists who are very comfortable with inborn errors of metabolism. But even whatever the situation may be, I think every neonatal unit and every pediatric unit needs a inborn errors, young these people like Suvarna and Dr. Chaitanya, this type of people. For each department, one person committed to IM. And for their departments where there are not there, these people can provide services, online consultation, because the diagnosis and the interpretation of these tests is such a complex thing that there will be like uh, there was a time long ago when I had seen two children with Fabry disease 30 years ago, and I was considered the expert in Fabry disease because I had seen two cases. So for all these disorders, if those are so rare that if she has seen two cases of citrullinemia, she must have read so much about these disorders that she is the expert in that area. So it's very important that you take help of these experts. And again, the importance of keeping updated, logical thinking, use of genomic testing judiciously is very, very highlighted. The point which we couldn't stress, but now I want to tell that you do NGS and you get some results. So the interpretation of results is also has to be very cautiously done. Don't think that
Mm.
there was something like you suspected some disease, cardiomyopathy, and there is some variant. But if there are or you suspected immunodeficiency disorder, and there are 50 genes for immunodeficiency, you will get some variations. So just to label immediately is very, very risky, because you may be labeling a normal polymorphic variant which is present in normal people but not very much in India. So somebody might have labeled as a disease causing variant. So cautious approach for the use of NGS based testing is very much needed. And for all these things, the diagnosis evolves over time. The cost of this test is very high, and hence communication is very, very important. It's not that you just write a prescribe something. You have to do all effort, pre-test counseling, help the family understand. Then if you have to arrange diet, so lot of things you need very, very good communication skills, and that probably everyone has to learn over time. And all genetic disorders have like complex issues of ethics, privacy, interfamily relationships, and all these have to be dealt appropriately, so that being expert of MSUD will not be the only useful, but you have to keep that family with MSUD at the center, so that once you keep the patient as a center, not the disease, and then the treatment will become successful. Lastly, I want to stress for all pediatricians, take care of children with Down syndrome very well, because these are the commonest ones. they can lead a very good, happy, fruitful, healthy life with the help of the clinicians, pediatricians, and give them positivity. Because of what I get feedback from many parents of children with Down syndrome, that pediatricians sometimes say, these are not, you don't do anything, then nothing can be done. But now we know that the children have reasonably good IQ, mild to moderate retardation, they are doing wonderful. Many of them are really role models. So probably we all pediatricians need to take care of children with Down syndrome in a best possible way, and bring them into normal life, normal society, and they should be able to lead normal life as much as possible. And these watertight compartments of retarded and normal people, these are not so watertight, and we should try to make them in fact part of our society, which where they can give, there will be give and take. It's not that only they will be taking, they will be contributing to the society as well. So again, thank Dr. Gokhale and everybody, Dr. Bisen and all the speakers for this wonderful session. Uh, Thank you for making me a part of it.
Thank you, madam. Your word expert wisdom have wonderfully integrated all three presentation into a coherent clinical framework. Thank you for guiding all of us. Also, I thank Dr. Magar madam for such an comprehensive clinical presentation with various cases guiding us in the management of IEM. Now we will proceed for the session of interaction and discussion, and I invite questions from the audience through the chat box.
I have a question. Can I ask a question to Dr. Suvarna?
Yes, sir. Yes, sir.
See, this recently, even we have learnt our lessons very bitterly, because we end up treating sepsis much more than the incidence rates which are reported all over the world. So,
Yes.
like the point you made is well appreciated, that we have to look beyond sepsis now, because it presents any metabolic disorder. It presents exactly as a sepsis, unless you take a call to decipher how they are in the various forms, like some start after feeding, some start immediately after birth, and various.
Yes.
So I thought that point was really well taken, and we have learned it a hard way. It was nice to see all the points and the gray areas where we were struggling in your
Right.
beautiful slides that you had put across. So thanks for
Right,
that.
sir. Thank you. Thank you so much, sir.
I shall also like to add one thing, that like in newborn situation, now with these NGS based testing, we know there are late onset presentation of all these disorders. So somebody child is good for well for 1 year, 3 years, doesn't mean and suddenly develop something, doesn't mean it cannot be inborn error of metabolism. So late onset presentations of OTC deficiency, MSUD, glutaric aciduria, a lot of them are there. In fact, Krabbe disease presenting at 10, 14 years and 40 years are also there. So it's very important that we keep all these differential diagnosis in appropriate situation, sometimes high up, sometimes at lower down, but always consider genetic disorders in your differential diagnosis at appropriate situations.
Yes.
Can I ask a question to Chaitanya Datar sir?
Yes.
Sir, can I? This is the era of AI now. Can AI assisted dysmorphology tools help a pediatrician in the future practice?
Dr. Chaitanya, you have to answer. And
Sorry, I couldn't hear the.
he was asking about AI-based tools for dysmorphology diagnosis in the coming era.
Okay. So essentially, when we're doing a dysmorphology databases, you have this Face2Gene apps, so which are available now. You can download them from the Play stores. Obviously, you're clicking those pictures, so you need to click proper pictures of the face of the various parts, and then that would help you with the diagnosis. So they will ask you various clues, so that you can filter down on the specific, the clinical presentation. So they'll ask you various features which you need to answer those questions one by one, and then they'll give you a list of differentials. That's how it generally works. So it works on heat maps. So based on the facial features, it works on heat maps, and typical syndromic faces. Those are the ones which are better represented. So those which do not have a, I would say, a classical face, those are the ones which sometimes they deviate from what you're really expecting or what the correct syndrome is.
Okay, sir. Thank you, sir.
So the diagnosis skills of these softwares apps are also increasing. What they were 10 years ago, now they are increasing. It depends on the database what they have. And secondly, how characteristic the facial phenotype, if it is very characteristic, it will detect. It's more likely that it will detect. But sometimes the subtle things which our eyes can miss, sometimes I feel that AI based testing also can identify. So one way is that something like Rubinstein-Thaby, Cornelia de Lange, which are very common syndromes. For us, they are common, but young pediatrician might not have seen that those patients, and for that, so the various ways it can be useful are like this: common syndromes, but the inexperienced pediatrician will be able to get those common easy diagnoses very easily. Secondly, for others, even with experience, but because they are rare diagnoses, it really helps us as well. But of course, we have to decide that it is just a list of differential diagnoses. And at present, it is your own logical acumen that you have to make interpretation. And lastly, sometimes what maybe Dr. Chaitanya and others can tell. Sometimes what happens, we get an unexpected diagnosis on exome sequencing. Like I got a mutation in a gene for Angelman syndrome in a like 6 month, 1 year old girl. She was not having that Angelman type phenotype, and I haven't seen any Angelman syndrome with monogenic causes. And but that app gave it as a first diagnosis. So it's possible that sometimes it is little better as well. So it can be used in a reverse phenotyping. This is called reverse phenotyping. When you get a diagnosis by NGS based testing, then you re-examine the patient for the features of those that particular syndrome detected by NGS based testing. And that can help you to decide whether it's the same syndrome, whether that variant is really causative or not. So various ways it's useful, and over years probably it will become much more powerful.
Okay, madam. Thank you. Thank you, madam.
Any further questions? Dr. Renu, can we go for conclusion of the program? Do you want to add any comments? So I think, Ritesh, I will just,
Yes, sir.
first of all, I want to thank all the expert Dr. Subha Phadke for being a mentor to the young voices. This field is not very easy, but what we saw in the last paragraphs of Nelson a few decades back is now actually what we are doing uh, today. That we are actually getting to the diagnosis, and we are trying to help out parents in difficult situations. So that is one technological and one knowledge hurdle that we have crossed from pages to genetics and to actual implementation. So I want to thank all the young voices, Dr. Naresh Tade, who gave a very nice talk, Dr. Chaitanya Datar. They had a very like all these three topics were interconnected. So it was difficult for them to really be focused on, but they have done a really excellent job. And I think this information and the knowledge gained from today's program, this program will be available on MahaIP YouTube channel for further. So we'll be sending a link later on to people who could not attend it. But I think this carried a wealth of information about the topics which we try to stay away from and like to touch less often. But these are going to become more and more important in future because of difficult choices to make when genetic conditions present. So I wish to thank all the office bearers of MahaIP and all the our audience who make it really possible for us to continue these programs. And once again, thanks to Dr. Shubha Phadke and the young voices, Dr. Naresh Taide, Dr. Chaitanya Datar, and Dr. Suvarna Magar. Till we meet again in the next month, I say goodbye to everyone, and we hope to connect with you again sometime in future for some similar related topic. Thanks to everyone.
Thank
Thank you
you.
so much.
Thank you very much.
Thank
Good
you.
night. Good night.
Thank you.